C'est un grand plaisir aujourd'hui pour moi d'accueillir notre collègue de l'Université d'Otago à Wellington, en Nouvelle-Zélande, professeur Maria Stubbe, et que j'ai rencontré il y a plusieurs années dans le cadre d'activités du Congrès international de communication en santé. Maria, elle est professeure titulaire au département de médecine générale et de médecine de première ligne de l'Université d'Otago. Elle est aussi directrice de son équipe de recherche ARC dont elle va nous parler. Et elle a travaillé, elle est sociolinguiste de formation, mais elle travaille avec une très, très belle équipe interdisciplinaire en première ligne. Et puis, elle va nous présenter des défis, entre autres rencontrés en première ligne, en recherche en première ligne dans son bout du globe, et puis nous donner quelques exemples aussi de recherches fort intéressantes qui démontrent, je pense, le grand éventail, la grande étendue des projets possibles en première ligne. So, it's a real pleasure, Maria. La présentation, comme c'est annoncé, va être en anglais. Alors, Maria, it's all yours.
Merci beaucoup, Lise et Marie-Thérèse pour l'introduction. Bonjour. I will carry on now in English, and I have received my coaching to speak a bit more slowly. I sometimes speak too fast, so I will do my best. So thank you very much for the lovely welcome here and the beautiful weather today. I think it is beautiful here in Montreal today, well, all week, but yesterday it was a bit cold. I'm not used to so much snow ever, really. Okay, so today I just want to give you a little bit of a taste of a little bit of context about New Zealand and some of the research we do in our department. To start with, I would just like, some of you have heard this already yesterday, but I would like to just start with a formal welcome in the Indigenous language of our country, Māori. And I've put the translation in English on the right-hand side so you can follow. This is the traditional way we introduce ourselves at formal occasions. So tēnā koutou katoa, ko te ahumairangi te maunga. Ko te moana a rokawa te moana, no horana te whenua o oko tupuna. Engari, e tipu ake au ki Aotearoa. Ko te whanganui a tara te wakainga o tōku whānau. E noho ana o ki pai kakariki. He kairanga ho e ahorangi tuhono aho I te wharewānanga o Otago ki te whanganui a tara. Ko Maria Stubbe tōku ingoa. Nō reira, tēnā koutou, tēnā koutou, tēnā koutou katoa. So this is a formal greeting. It is traditional for Māori people to locate themselves in the land where their origins are. Or in my case, as a migrant, the place I have come to from my origins. So Te Ahumairangi Marie-Thérèse has seen this hill. It's the one opposite Wellington Harbour, and Cook Strait is a very bumpy piece of water that you cross on a ferry. And the word whānau, that actually means family or extended family. So just to give you a little taste of what it is like. Okay, so I'm going to just give you a little bit of context about New Zealand and the New Zealand health system, and a little bit about the funding landscape for research, for health research in New Zealand. And then I'll tell you a little bit about the University of Otago, Wellington, particularly the research in my department and my research group, the sorts of topics that we look at. And then I will just give some examples of some translational research that my research group, the Applied Research on Communication and Health group, has done, looking at health communication, but also health services research in primary health care. Okay, so Aotearoa, that's the Māori name for New Zealand. So that is how we sometimes refer to our country, and we are a very small island nation in the South Pacific at the opposite end of the world. It's the last land before the South Pole. We have a colonial history. So the Maori people arrived in New Zealand really only about 800 or 900 years ago, and they navigated in open canoes across the open waters of the Pacific. It's amazing, yeah. Our colonial history, mainly British, but actually the first European discoverer of Aotearoa was Abel Tasman, a Dutch navigator. He got scared off because he did not get a very friendly reception, and but he left the name behind. New Zealand comes from Zeeland in the Netherlands. The British were next. Well, actually, before that, the whalers and the sealers. So there was no government. The whalers and the sealers came and made contact with the local people and hunted the whales and the seals. And then the British followed and started to settle there in competition, I have to say, with the French. So there are two regions in New Zealand, one at the top of the North Island, the Bay of Islands, and one, if you can see, there is a little bump in the middle of the South Island that sticks out at the bottom. That's called Banks Peninsula. And there is a little town there called Aotearoa. And everywhere you walk in Aotearoa, there are French place names and street names because it was also settled by the French. But the French did not win the colonial competition in New Zealand.
In Canada either.
So we are predominantly an English-speaking country, but a bicultural country. I'll tell you a little bit more about that in a moment. We have a very multicultural population, although it is very small by comparison with Canada. So during the COVID pandemic, our Prime Minister Jacinda Ardern referred to us as the team of 5 million. So because we're a sporting nation, so team, good metaphor. Actually, there's somewhere between 1 and 2 million New Zealanders who live in other places, in Australia, in Britain, really all over the world. So they did not really feel part of the team of 5 million when the borders closed and they could not come home. In the 2023 census, we don't have all the data back yet from that, but the initial data, our total population is 5.2 million. And of that, the New Zealand Europeans are approximately 68%. It used to be more in the mid 70%. So it is proportionally a little less. The Māori population, just over 17%. We have 8.1% of our population have their origins in a number of the different Pacific Island nations. So they are really quite distinct cultural groupings, but they are grouped together for statistical purposes very often. Actually, the second largest minority group is people of Asian origin from all over different parts of Asia, including the Indian subcontinent, and Middle East, Latin America, and Africa. And it's a very small percentage. And those mostly these people are from our refugee origin population. So that graph, it's from slightly out of date statistics, but it gives you a little bit of an idea of the makeup of the country. Okay, so we are a little bit unusual in the Commonwealth in that we have a founding document called the Treaty of Waitangi, which was signed between the British Crown, Queen Victoria, and the Māori chiefs in 1840. So the Māori are the indigenous people. They call themselves the tangata whenua, the people of the land. And it was signed between them and what at the time they called the Pakeha, the Crown, the white incomers, who nowadays are often called tangata tiriti, along with all the other immigrants who have arrived in the last 180 years who are not necessarily of British or European origin. So the Treaty of Waitangi supposedly guarantees many things which have not been honoured over the years, including equal health outcomes for Māori and non-Māori, but the differences in health outcomes and many other aspects of life are stark and long-standing for the Māori population. So we still have large disparities in healthcare access and outcomes for Māori and also for our Pacific populations. In terms of our health system, our government decided it would be a good idea to have a major reform of our health system in 2021, just as we were, still in the middle of the COVID pandemic. I don't know why, but anyway. But overall, this gives you a very broad overview. We have a public hospital system, but elective care is rationed. And so an increasing number of the people who are better off economically will choose to have private health insurance so that they can, like I did a few years ago, get cataract surgery or get a bypass or get varicose veins treated or hip replacements a bit faster than they can access these things in the public system. But primary care has always been a mixed model, so it's not like the British National Health Service. So GPs are private practitioners. They're actually like private specialists in other specialty areas of medicine, and they run practices and they employ nurses and other health professionals in their practices, and they get population-based funding from the local, from regional authorities that look after primary health care. And that is so when you go to attend your GP, you pay a fee, which is subsidised for low-income patients and for some patients with chronic conditions. So this gives you an idea of how small New Zealand really is. So we have only 5,500 specialist GPs. We also have other doctors who do work in general practices, who are qualified practitioners, but not specialist GPs. But they are spread over approximately 1,000 practices around the country. And between them, they have about 14 million consultations each year. The health practitioners, as you can see, the minority groups are very underrepresented amongst GPs. The picture is slightly better for nurses, but not really very much better. We have a national drug buying agency, PHARMAC, that buys medications in bulk, negotiates with the big pharmaceutical companies. And that can become quite a political process sometimes because, of course, with a small population, the numbers of people with certain more rare conditions are very, very small, and it can be very difficult for them to obtain public funding for their medications. I was involved in an evaluation of models of primary care. There's a reference at the bottom of the slide. And although you might think that this would already be known, one of the tasks of this was to actually determine what were the models of primary care that were currently operating within New Zealand. So we have the traditional general practice, we have corporate models, we have a number of traditional practices which have converted into healthcare homes, a bit like I think you have medical homes here in Canada. Primary health organisation, district health boards, the latter are now defunct after the reform. So sometimes if there was a practice that could not sustain itself, it might have been in a rural area, for example, or a very low income area. Sometimes the local hospital or the primary health organisation would step in and take over the practice and run it. Sometimes non-governmental organisations or trusts would run practices, and we also have Maori and Pacific providers. So it's quite a mixed picture, and there's a lot of overlap between the models. So the brief for this evaluation was, please tell us which model of care is the best, which is going to be the best at increasing the quality of outcomes. Well, of course, it was not ever going to be as simple as that. And all my colleagues on the team who were primary care clinicians already knew this before we did the evaluation, but we had to present the evidence. So if you're interested, I can certainly send you a copy of the article, which has been published. Patient health outcomes, not surprising, differed between the models of care, and overall, Māori and Pacific peoples and people living in material deprivation have poorer outcomes from primary care. So it's a common story everywhere. At the moment, we have some particular challenges. We have really significant workforce shortages across the health sector. I think we have an ageing GP workforce. We have GPs in rural practices who cannot find anyone to take over from them, and they continue working until they're in their mid-70s because there's no one to take over. We're short of nurses. This is across both the hospital sector and primary care, midwives, community midwives and hospital midwives. And of course, the health system reforms are still in progress, so everything is in a very unsettled state at the moment. In terms of funding for health research, we are a small country. We don't have a lot of money. And even then, as a proportion of our GDP, we do not spend enough on any kind of research, and it includes health research. So government funds, the major funder is the Health Research Council. The money is taxpayer money. And they put out $126 million a year for competitive funding rounds. Until the middle of this year, for the last 10 years, the government invested in 11 science challenges, which was designed to increase collaboration between universities and between universities and other science institutes. And 3 of those had a specific focus on health. So one on the aging population, one on children, and one on lifestyle diseases, really, I suppose. We have another science funder, the Royal Society of New Zealand, and they do fund some health research, but they also fund a lot of other blue skies, fundamental research, and other ministries have some funding that they make available for application. And then from time to time, the Ministry of Health and other agencies will commission, they'll put out a request for proposals in relation to specific policy objectives that they have. Beyond that, there are various charitable or non-governmental organisation funds. They tend to be very small amounts of money. We don't have a very well-developed philanthropic establishment in New Zealand, say compared to, I don't know what it's like in Canada, but say if we compare it to Australia or the United States, it's very limited. There is some internal university funding that you can apply for. It tends to be for seeding other research. In order to get that, it might be $50,000 or $10,000, very small. And you have to make the case that this will help you to get one of the bigger grants later. Now, new this year, New Zealand has been granted entry to the Horizons Europe scheme for the first time. We're the first, and Canada too. Wow, yeah. That's great. Yes. New Zealand is the only Southern Hemisphere country that is now in that. Not Australia? Not yet. Oh. They are on their way, but not there yet. Believe me, I've been getting a lot of emails from my research advisors saying, don't forget, we're ahead of the Australians. But of course, we have to have a European partner. And since Brexit, that can't include the UK, where we have a lot of natural collaboration. So that's, you know, not every researcher in New Zealand has good links with people in Europe. So this is, it'll be interesting to see what happens. Okay. So, how are we going for time? Okay, so this just to give you a little bit of a taste of my department. So I have twin responsibilities in my department. So from last year, I became the co-director of research in the department. There is another researcher, mid-career researcher, who is going to take over maybe next year. So we are in a sort of interchange year at the moment. But I also direct the Applied Research on Communication and Health group, which was sort of, well, when I say formally established, we decided we would establish it in 2005. It doesn't really have an official status within the university, although we do have a web page. So I think we do have some status. So what we do in our department, it's like, I guess it's typical of primary care research. We're very broad. Over the years, we've had strategic days where we've said, oh, we should really focus on our strengths and have a particular focus. And then that lasts for maybe 1 year, and then people go off to their own interests or the opportunities or where the funding is. So we've never really succeeded in having a very, very tight focus of our research. But I guess where there is a focus, there's a very strong focus in our department on interdisciplinary and interprofessional research. And translation into health policy and health delivery, and addressing inequities in health access, use of, and outcomes from health services. So these are some of the key research themes at the moment. So addictive and lifestyle behaviours, communication and healthcare, which is my research group, educational research, health services research, and mental health. There's a lot of crossover. Every time we put together a team, typically there are people from different parts of the department and our school, and actually from other universities often as well. So I don't expect you to read through all of those topics. You can have a look at them later if you like. And I've put our website there in case you're interested in following up on anything there. The photo at the top, that's a picture, sort of a composite picture of our harbour, our waterfront. And the picture on the right, yeah, it can be in other ways, is a kakadu, which is a traditional feather cloak, a Māori feather cloak, which is was donated to our campus by a local weaver. It took many, many hours to make. So the title has got a bit hidden there. It's our research. This is a very old photo. Applied research on communication and health. We just call it ARCH for short, for obvious reasons. And we have always been very focused on translational research. So I came from a background in humanities and social sciences, as Marie-Therese said, and sociolinguistics, but even there I was always very interested in action research and translational research. So it made sense to keep that going when I moved over to health sciences. And we've always had a very strong philosophical focus on research for and with, rather than research on participants, whether those participants be clinicians or patients. And there's the website link for our research group. So over the years, we have been involved in many different projects, and because of my background in linguistics and sociolinguistics, I was also involved in developing a corpus of New Zealand English, which was part of an international corpus of English, where you collect recordings of language so that people can research language change and variation and differences across dialects and that sort of thing. So it was a natural extension when I moved to the medical school, and we started to collect video recordings of health interactions. And my colleagues said, oh, well, I suppose we have to tell the ethics committee that we will destroy these recordings after 10 years, which was the regulatory length of time for health data. I said, what? Really? It's cost us this much time and money and energy and, you know, to get this, and there's so much more we could do with this. So in 2005, we decided that we would establish ourselves as a research group with this resource, and we put quite a lot of energy kind of off the side of other projects to developing a corpus. So we have a searchable collection. It's a living archive, so we keep adding to it. Video recorded health interactions and associated data, which increasingly has come to include a lot of interview data as well. And it's held at our university campus in Wellington. And importantly, we have got ethical approval and consent from participants to reuse this data for research and education, on the condition that if it's a new project, it goes again to the ethics committee for approval. And we have a governance group, so we govern access to the data and put conditions on the use. So this was in a time when we really weren't operating yet in the cloud. We were doing this on hard drives, computer hard drives, and we were still recording on videotapes, DVD type videotapes. So it's become more complicated now in some ways. So these are our primary sort of data sets. So in total, actually, this slide is even slightly out of date because I didn't have a chance to add the most recent set of consultations and interviews that we've recorded. So we have actually over 500 health interactions, and I think getting up to 200 research interviews, some of which are narrative style health experiences interviews. And we have well over 533 participants now over many different healthcare sites. And on the right, you can see some of the kinds of data that we collect. And we've gathered all of that together. We use an Access database, but we link that to a catalogue, a file directory system, which we were helped by a librarian to design with different layers. So the most confidential data is only accessible by me and my two data managers. And then so we go out to things that are, if we've created resources that are de-identified, and then they may be available more publicly. And we keep ethnographic and demographic data and administrative data as well. So this has been a major exercise really to keep this going over the last year, because we were never funded. We were never funded to set this up. We
That's
just,
what I was gonna ask.
no.
Okay.
So we were able to, with the first big grant that we got from the Royal Society, we were able to persuade them that in order to do the actual research, we needed to collect baseline data and we needed to organise it. So we needed funding to do some of this work. So we got a start with it. So that was, I don't think we would be able to do that now because funding is much tighter. So this is one of the studies that it's we've been doing work in one way or another on type 2 diabetes and associated lifestyle, healthcare, health promotion work really since about 2009, so over quite a long period of time. And this particular study was one where we tracked newly diagnosed diabetes patients for 6 months from the point where they were diagnosed. At that time, their diagnosis was done by means of a glucose tolerance test. So this is, you can see, it's a long time ago. And we had a code where half the patients were from Wellington and half the patients were from Auckland. So it was a collaborative study. And included quite a number of Māori and Pacific patients, particularly from the Auckland cohort, because the data was collected mostly in South Auckland, where those populations are concentrated. So 32 patients, and we've recruited them at the point of diagnosis, recorded that first consultation with the GP, and then all subsequent consultations for 6 months, whether it be with a nurse, with a dietitian, with a podiatrist, with an optometrist. And then we did exit interviews. We also did brief interviews along the way every time we recorded them. And we used ethnographic analysis and also interaction analysis, so really sociolinguistic interaction analysis, which is related to but broader than conversation analysis. And really the research question was around, would it be possible to identify ways to improve the management and patients to help them start to self-manage on the journey to self-management, and to look at the teamwork or lack of teamwork in some cases between the primary healthcare team. So all of the practices that we worked with said, well, of course we work as a team. And we didn't dispute that, but when we sort of fed back, we posed that question again, and they were able to critically reflect on our findings and decided that perhaps there were ways they could strengthen their teamwork. With the focus on the communication, we looked at the consultations in a lot of detail, and the clinicians very proficient. They had a lot of knowledge, obviously, about the disease, and they had good general communication skills. But nevertheless, the initial consultations were often very biomedical in nature, and the patients reported that they found that the amount of information and the way it was delivered really overwhelming at a time in their lives when they were feeling psychologically very vulnerable. There was a lot of information that was repeated, which wasn't necessarily a bad thing, but it wasn't necessarily relevant to the patient at the time that it was being given. And the health professionals themselves had very little knowledge of what went on in consultations with their colleagues. So this was sort of written up. And what we did actually at the time of the study was that we tracked, and you could see here is the Wellington, the 18 Wellington patients, and they had quite varied amounts of contact time, and there was a lot of variation in which kinds of health professionals they saw. I mean, the GPs and the nurses were the core, but it was a very variable picture. On average, they would spend 1 to 2 hours in total over 6 months talking to a health professional, but that was on average, sometimes much more. So we took some of this information and some of the transcripts, and where we had permission, even some clips of videos back to each practice. And the professionals often agreed for us to show some clips from their own practice because they found it very valuable. One of the things that they said to us at the start when we were consulting, they said, oh, we don't have enough time to consult with these patients. So that was a question that we incorporated in our research. And yeah, so one patient, one of the ones with the shortest amount of time, still got over 2 hours of time over the 6 months, and a very complex patient with very complex needs, 7 hours and 12 minutes. So we put that to the practices and said, is it really not enough time, or is it how the time is being used? And we just invited them to reflect. We didn't say that, you know, this is our recommendation. We just invited them to reflect. So it was an interactive presentation. So we kind of curated some of our key findings and presented them, and then invited discussion and problem solving. So really using a kind of reflection, action model, plan, do, you know, the usual kind of quality improvement model that we're all used to. And here's an example of a bit of transcript from a consultation. So I think this was a dietitian consulting with a patient who came from, had, you know, a lot of socioeconomic challenges and had a very big family, a multi-generational family. And the dietitian was saying that she was doing it all wrong. She needed to cook and eat very different food. Well, they're hearing I'm cooking wrong because there's 11 of us. Oh, 11 of you? And you cook for everyone? Oh, that's a big job. It's about who I look after and care for, but sometimes I'm not eating till about 9:30. Okay. After I've done, because Nanny's 89, and the youngest niece I have in my care, she's 2, and we cook bulk and stuff like that. Okay, well, that's all right. Well, what we'll do today is just have a bit of a chat about your lifestyle and the type of food you typically eat. I was not listening to any of this saying, why don't you eat brown bread? Well, because it costs $5 a loaf and I can buy white bread for $2 a loaf. Anyway, no one in my family will eat brown bread. You know, so these were the sort of the kind of cross-cultural challenges as well, or not really even cross-cultural, cross-economic challenges really. So anyway, so we quite often we would present, just let the patients speak for themselves, or let the interaction speak for themselves. Okay, so we continue to do this kind of work, and one of the spin-off projects was one around weight management support in primary care, and we were actually commissioned by our local primary health organisation and funding from the Ministry of Health to come up with a different way of providing weight management support in primary care that would have a greater focus on teamwork, because so we created an EMR screening template where whichever health professional was talking with a patient about some aspect of their lifestyle, it could be recorded, and then there was a chart. So the next time they were seen, maybe, you know, the first time it was the GP, the next time it might be the nurse, the next time it might be the dietitian, they could see, well, this topic has been raised before with this patient. At that time, they were not interested, or we raised it and they were a little bit interested, and it might be useful to follow it up. So the idea was to try and support more integrated care. And it was quite successful, but we didn't succeed in having it integrated across. So it didn't really translate into practice in terms of implementation. So that is a challenge because we have such a decentralized primary care system. Oh. Sorry. Okay, so that's just a very little taste of how we're going for time, Marie-Therese. Have I got a few more minutes?
22.
Okay, we stay
20.
I should stop. I'll just spend a couple of minutes on the health services research. Yeah. I'll do it very quickly. And people can talk to me about any of this research later or send me an email if you wish. So my team, we were finding it increasingly difficult to get funding for our first love, which was the health communication research, and we continue to do that. Sometimes we refer to it as our hobby because we have to do it in our spare time. But where the research funding was health services research. So we also do health services research, but we actually bring our qualitative research and our communications focus to that very often. It's been interesting having to reposition our team. There are some people in my team who say, well, I don't think that's arch group research. it's different. I said, no, I'm not sure. So we've been having some ongoing discussions about that. So we were involved in a big evaluation of the training and workforce support for the COVID-19 vaccination program. So vaccinating 5 million people twice in 2020 and 2021. And we learned a lot from doing that evaluation about particularly the innovative vaccine delivery models that had been developed by Māori and Pacific providers to reach out to their communities. I won't say very much more about that now, except that it involved having workers who came from those communities and were trusted by their communities, and using all sorts of creative strategies to take the vaccines to the people and to encourage people to be positively motivated and to have their questions answered. So after that, we got some funding to work with 7 of the providers that we'd identified all around the country. So that was purposive sort of selection of those providers who had used some of those innovative models with a view to documenting some of those models so it would be useful for others. And now we are going back to our hobbies we are developing proposals for conversations about childhood vaccination, because a lot of the workers, the unregulated workforce who were trained to support or even deliver vaccinations for COVID-19 there are micro-credentials available, so they can now immunise a whole range of adults and children across the immunisation schedule that we have in New Zealand. And we are and what the problem is that there's been a big reduction in the percentage of children in particular, and also young adults who are vaccinated. We are down to less than 60% of Māori children under 5. It was in the 80s before COVID, so this is really dangerous. So we're interested to directly observe those conversations and see what can be learned from them so that can help other Māori providers, but also mainstream providers working with Māori families. And then we've got a very tiny amount of seed funding to work with the Pacific Island community group in the South Island. This research question came from them. From their observation, they have, in that particular community, quite a number of first-generation migrants from the Pacific, and they're living in a rural area. And they were used, when they were living in their Pacific Island homelands, essentially to do what they were told by the nurses and the doctors. And they continued, so they were very accepting of the COVID vaccination, but they weren't accepting of it for their children once they became available for children 12 years and under. It's fine for me, but I'm not going to do it to my kids. That was a quote from that. So we're just doing a little bit of focus group research to explore that a little bit further this year. And then some other research that we have become involved in is part of a very big research consortium in New Zealand, which in fact is funded by Flu Lab, which is a philanthropic organisation based in Boston. I think that the funding from that comes primarily from Laura Page and Mrs. Google. And they approached our colleagues at Auckland University. You don't apply to them, they come to you, apparently. And Auckland University came to us and say, oh, you're very good at doing this qualitative research with communities. Would you like to do a scoping study for us? We've got a cohort that we've been working with. They were taking blood samples and doing tests for influenza and COVID and RSV in a very intensive study with over 500 households in our city or our region. And they wanted to have some in-depth qualitative work done on the acceptability and use of non-pharmaceutical interventions. So we did that, and what that led to was a pilot study, which I'll just show you very briefly next as my last slide, the use of point-of-care multiviral rapid antigen test. These people, they were a very sophisticated cohort and from all walks of life and all ethnic backgrounds, but without exception, they were very nuanced in their decision-making about how they would manage transmission once they knew that somebody was, had a positive result from a test. Now, these were PCR tests, and they said it was good if we were tested on Wednesday, and they were very good. They'd get back to us within 24 hours, and we would know, and then we could keep the children home from school or whatever it might be. it was useless on a Friday because then we wouldn't find out till Monday. And of course, the weekends that when the children's birthday parties are, we go and visit Granny at the rest home, we go to sport, all of those things. Why can't they have a test like the COVID rat test for flu, for RSV? Because we had big spikes in flu and RSV once our borders reopened. So we thought, indeed, why not? So we spent a bit of time researching it and we found a validated test in Australia that had been passed by their regulators, and we imported about 2,000 of those. And it was actually already midway through the flu season by the time we did it last year. But we basically did it as a feasibility pilot to see if this would be acceptable and feasible in a primary care setting to both the clinicians and the patients. These two studies have since peeled on to 3 new studies in the Auckland area, also looking at a range of measures to halt transmission of winter viruses. So one with the Samoan Church, one with preschool children, so that Kohanga Reo, that is a Māori language preschool, looking at winter preparedness, and then a third one surveying parents, caregivers and teachers, and doing some activity-based focus groups with children at primary schools about respiratory illnesses post-COVID. So those studies are ongoing. We've completed the pilot test. We're now currently trying to see if we can roll it out into aged residential care around the country, if we can get funding. I'm feeling very embarrassed because it was a very tiny amount of funding compared to what you are going to be doing in Canada in this area. But nevertheless, we're hoping to publish this quite soon. So we basically went to a traditional general practice with a more middle class kind of practice population, a central Wellington urgent care facility, which draws from the whole area, and an area to the north of Wellington City, Porirua, which is very multi-ethnic with a high number of Māori and Pacific and also refugee and migrant populations who live there. And even though we were late in the flu season, COVID continued last year, we had an overall positivity rate of 14.5%. I think that would have been higher earlier in the winter. We surveyed patients and clinicians. We did in-depth interviews with patients. We surveyed the clinicians, as I said, and we ran focus groups with the clinicians. So it was a very intensive study. We got it up and running in less than 8 weeks. We ran it, and then it was all completed. It was all done and dusted within 7 or 8 months. So we're just in the process of writing that up now. So that's just a little taste of some of the things we are doing. I'm sorry I've run over time.